The next speaker is Dr. John Paul Pepper, who is the director of the Stanford Facial Nerve Center, and he's going to give a speech on treatment of facial dysfunction and facial reanimation.
Great. Thank you very much, Dr. Chang, and thank you to all the conference organizers for inviting me to speak today. As Dr. Chang just said, I'm a facial plastic and reconstructive surgeon and also the director of the Stanford Facial Nerve Center, where we run a truly multidisciplinary treatment effort that's focused on the paralyzed face and related facial nerve disorders. And I'd like to share for you some of the treatment offerings that we have that can be useful to the subset and minority of acoustic neuroma patients who may require our expertise. I have no financial disclosures. So there are multiple outcomes in terms of facial function that can relate to acoustic neuroma treatment. And I have 3 acoustic neuroma patients of mine who highlight some of these different outcomes. There's actually one missing, which is the most common outcome from treatment of an acoustic neuroma is no facial dysfunction, thankfully, due to the world-class treatment team that we have here and at other centers around the country. If there is abnormal facial movement, it's actually not just an on-off situation where it's all movement or none. There's quite a spectrum of movement, as you can see here. The most rare outcome, thankfully, is complete unilateral facial paralysis, and that means no movement on one side of the face. That is quite rare. The center photograph shows you an image of synkinesis, and I'll delve into this in more detail. This is somewhat more common, and it refers to some unintentional movement that can occur in the face after treatment or after any injury to the facial nerve. There can also be simple weakness. So there is some movement. It is purposeful. It is volitional. However, it is not quite symmetric. And as one side of the face retains normal function, full exertional movements can really highlight a facial asymmetry that can still be debilitating even though the patient can move their face in all portions of their face. So as this is a pretty complex problem, and it does not relate only to acoustic neuroma patients. I see patients who have tumors of other types, stroke, trauma, you name it. There's a wide variety of reasons for coming to see us, but we do offer a truly multidisciplinary team that is world-class and unique in this region and in this part of the country. I run the center. I'm a facial plastic and reconstructive surgeon. You may at first glance wonder kind of how those two things fit together. And I hope that by the end of my brief talk today, that it will be very clear, very plain. A portion of my practice is aesthetic surgery. And some of the principles that I apply in terms of bringing minimally invasive treatments to rejuvenate the face and that type of aesthetic approach to someone's face are actually very helpful in how I design treatments to complete facial paralysis. We have an embarrassment of riches, though, in terms of expertise. We have one of the best rehabilitation specialists, a nurse coordinator par excellence, and then, of course, neurologists, neurodiagnosticians, neurosurgeons, and neurotologists, many of whom you've heard from today. This is a living, breathing center where we work shoulder to shoulder to treat a very difficult clinical problem. We have a monthly case conference where we present these cases and design a multidisciplinary treatment for each patient, particularly for the more challenging cases. And we brought all of that expertise together just 3 weeks ago with the first Stanford Facial Nerve Symposium, which I co-directed and was very pleased with. So as I said, this is a living, breathing entity where we work together shoulder to shoulder to provide the best care. And so I'm going to talk about my work, but also some of my colleagues as well, as they are commingled and they're impossible to kind of extricate and separate from one another. And in my opinion, that does lead to the best outcomes. So I'm going to start first by discussing synkinesis. And this may be something that some people in the audience are already familiar with, but this talk will presume that you have no pre-existing knowledge of what it is. So the straightforward definition is it's unintentional movement in one part of the face when you are intentionally moving another. So for example, your eyes close too much when you smile. Everybody's eyes closes a little bit when we smile. That is normal. However, too much can give the face too much asymmetry. And in fact, the spasm can be so dense that sometimes it can cause pain. So if you take a closer look at my patient's face, the right side of the face, her right side, your left side, is affected by synkinesis. And you can see that her right eye is closing a little bit more than the left eye. That partially obstructs her vision. But a more careful analysis of the face will reveal that the neck muscle on the right side of her neck is more protuberant, more obvious. So there are subtle asymmetries, which can be very meaningful to the communication of the patient and can cause them some dysfunction. What this is basically a faulty rewiring. So the facial nerve goes from the base of the brain to the face, and it has multiple branches. A branch can go to the muscle that elevates the corner of the mouth, indicated by the blue arrow. After any form of injury or treatment, the facial nerve attempts to recover. It sends regrowing nerve elements to the muscles, but it may go to the wrong location. So that's what you see here in green. And this is showing you that the portion of the nerve that used to be responsible for moving the smile muscle is now closing the eye. So the harder you try to smile, the more your eye closes. And that is the essence of synkinesis. It's a very difficult problem to treat. The first-line treatment is actually through my colleague, Sarah Strandberg. She's a speech and language pathologist. She is wonderful and provides world-class treatment. And this is really the entryway point, kind of the first starting point for treatment of synkinesis. And what she does, and this is a very brief slide encapsulating some of the treatments that Sarah offers, and there is much more to this than just simply this one slide. But it is a very individualized form of treatment, and it's based on a thorough assessment of facial function where she can tell you what to do, but then secondly, what not to do. And I think that the second point can be as important as the first. So we want to accentuate functional movement, but then try to de-accentuate non-functional or unhelpful movements. The goal overall is to improve facial symmetry, but really to improve the patient's ability to communicate. For any amount of synkinesis that is not effectively or satisfactorily treated by rehabilitative exercises with Sarah, we will then transition into what is essentially the second step of treatment, and that's the use of botulinum toxin. That may be familiar to some of you in the audience. Botulinum toxin is a toxin, but it is made and manufactured in a purified form. It can be injected into any muscle in the body. It will cause 3 months of paralysis. So it paralyzes temporarily the muscle into which you inject it. The goal of this is to reduce unwanted movement. So this is applied after a careful assessment of a patient's face, identifying the areas that are moving when they're not supposed to, and injecting botulinum toxin into those muscles to give you 3 months of relief. The downside is it is temporary. It is 3 months. As I tell patients, that's also the upside, because if you don't like it, it is reversible. It is going to go away. But it is quite effective when applied in the correct patient. This is just a sample patient, and those numbers represent the units of botulinum toxin that are injected into the muscles of the face, where they're injected, and in what quantity. As I said before, as a facial plastic surgeon, some of the aesthetic treatments that I am familiar with and that I have expertise in are very useful in terms of refinement procedures or additional procedures to help patients make incremental but appreciable gains in their facial symmetry. These can run the gamut, and they go from top to bottom of the face, from brow lift, blepharoplasty or upper eyelid surgery, the use of hyaluronic acid filler, and then really a workhorse procedure, the facelift and a neck lift. All of these can be used quite effectively to treat facial paresis, weakness, synkinesis, and in some cases, facial paralysis. So the facelift is, in reality, the oldest facial paralysis surgical treatment that exists. The oldest treatment that was offered for a patient with a paralyzed face was a unilateral facelift. It can improve symmetry in patients who have weakness, and it can be used as an entryway and access point for patients with synkinesis. If you recall, I was just discussing the use of botulinum toxin. That targets nerve branches that are supplying muscle that are spasming and causing unwanted movement. In some patients, in some muscles, we can use the administration of Botox to demonstrate to us and our patient which muscles and nerves can be safely denervated or cut. And so a facelift can be used as an access point for a procedure called a selective neurectomy. So for instance, in the patients, the photographs that I just showed you, if there's unwanted movement in the neck muscle, we can, at the same time as performing a facelift, access the nerve branches that are going to the neck muscle, cut the neck muscle, and the nerve branches that are supplying that. That can be an effective way of improving facial symmetry and facial movement as in I show you a patient here. You have to look carefully at the neck to see that there is less contraction in the muscle of the neck. This is not equally effective for all facial muscles. Not all muscles can be treated the same way. However, in general, the muscles that depress the corner of the mouth and bring it down are not as functionally useful or functionally relevant as those that close the eye and those muscles that elevate the corner of the mouth. Quite similarly, an endoscopic brow lift, which is an aesthetic procedure, but it is minimally invasive and uses access points within the hairline or behind the hairline, can be used to dissect down to the muscles around the eye and the eyebrow to release and weaken these muscles. This is done as an aesthetic treatment for people who want to eliminate lines and wrinkling. However, in a patient with synkinesis, when they are trying to smile, abnormal activation of the muscles around the eyebrow, which you can see in the patient whose photo is on your left, can impart an entirely different emotional state than they are trying to convey to you. Releasing these muscles allows the patient to have a slightly different emotional expression, even though the exertion is exactly the same. This, again, is not true for every muscle in the face and for every patient, but these are some of the skills that we can bring as an asset to our patients in terms of comprehensive treatment. As a separate matter from refinement surgery, surgeries to make incremental improvements, patients who have complete unilateral, meaning on one side of their face, paralysis, need a stronger procedure, a workhorse procedure to resupply the face with functional nerve and/or functional muscle. And so this is a more significant, in my opinion, clinical problem. Facial paralysis has a significant impact on life quality, and I have some of the issues enumerated here for you. It makes normal emotional expression in speech very difficult. The eye cannot close, the lower eyelid droops. These can compromise the health of the cornea. There is, of course, an asymmetric smile, and this can be severe enough that it's difficult to hold food and drink in the corner of the mouth, and speech may be severely impacted. In these cases, we consider patients for procedures that we entitle facial reanimation surgeries. These are surgeries that are designed to restore either or both the resting symmetry and some movement of the face. I would like to take one step back. There is no perfect procedure for these. I'll show you some sample surgical results, but the closer you look, particularly at video, you'll realize that there is no perfect restoration of facial function. However, we have made significant advances, particularly in the last 10 years, with regards to our surgical offerings. So, who gets these procedures? Simply, not everybody. The average patient who shows up and maybe has post-operative or facial paralysis from tumor growth is not necessarily going to undergo a facial reanimation surgery immediately. There is a period of watchful waiting, usually on the order of 6 to 12 months. During that time, we consider patients for testing if we don't see any clinical signs of movement, and so the face does not appear to be moving on one side at all. We can do a specialized form of testing, kind of like an EKG, to assess the electrical health of the facial muscles and tell us if maybe recovery is just around the corner. If it looks like the electrical testing shows no signs of recovery, we begin to put together a treatment plan. During that first 6 to 12 months, we're taking great care of the eye, either through medical or surgical means, so there is a lot going on while we're putting together the treatment plan. And I'll show you now a couple patients who have undergone facial reanimation surgery. So this is a sample acoustic neuroma patient who I treated within the last several years. She had facial paralysis that occurred during regrowth, unfortunately, of an acoustic neuroma that had been treated surgically before. She had no evidence after about a year of watchful waiting, either from clinical examination or from electrical testing. There was no evidence of recovery. So we performed a facial reanimation surgery about a year after the onset of her paralysis. We performed a procedure called a dual nerve transfer for facial reanimation. This is a procedure that I've just recently published, and I'll describe for you in broad strokes here. And this is just her video, and I'm going to show you some patient video now, and she's not moving any portion of the right side of her face, but the left side is completely unaffected. And this is her doing a variety of standardized movements that I have all patients do as part of their assessment. The incisions for this procedure are all born and derived from facelift incisions. We try to hide as many incisions as we can around the ear. That is what is done in a facelift, and so that is the origination of the incisions that I use for all facial reanimation surgery. What this is in essence, the rewiring of the paralyzed facial nerve or the injured facial nerve. I am identifying regional, meaning nearby motor nerves that I can connect to the facial nerve to resupply movement. It does not give perfect movement, it does not give completely normal movement, but it can lead to impressive results. So this again is my patient's face. On your left, she's not moving any part of her face. This is her 6 months after surgery. There still is certainly asymmetry. She is then going to use another motor nerve. It's actually the masseteric nerve, which is used for biting down. She is going to use that to bite down to initiate a smile. This is the most powerful means of initiating and rehabilitating the paralyzed face, in my opinion, in terms of producing a smile that looks natural. And this is her again, and I'll skip over some of these videos just for the sake of brevity. And this is her 14 months later. At this point, she's actually had some additional procedures, including an implant that helps camouflage the junction between her jowls and her chin, a little bit of hyaluronic acid filler in the cheeks just to balance the cheeks. So this is where aesthetic treatments are actually very important to restore the face and to give that kind of je ne sais quoi of normalcy, that kind of right brain analysis of what looks more normal to a person or to a patient. These are other examples of similar procedures where patients have had their faces reinnervated after acoustic neuroma or similar brain tumor surgery. This is a patient of mine who had complete left-sided facial paralysis, and this is her early movement using the masseteric nerve to restore her smile. Similarly, this is a patient who underwent dual nerve transfer. She had a history of an acoustic neuroma, a very large acoustic neuroma, no movement on the left side of her face, a similar watchful waiting period of about 12 to 14 months to make sure that the face was not going to recover on its own. And this is her post-treatment result with her initiating a smile and then her doing various standardized facial movements. You notice there is no recovery of the eyebrow. There is no recovery of some parts of the face. I cannot make someone's eyebrow elevate again if it's completely paralyzed under any circumstances, at least as of today's technology and today's surgical capability. And lastly, that's another patient who had undergone the same procedure, a masseteric nerve transfer, and after an acoustic neuroma, the right side of the face is completely paralyzed. He's had a masseteric nerve transfer that he's using to smile, and he is biting down to initiate his smile. He has also had a platinum weight implanted in his upper eyelid to make his eye opening more symmetric, and I did a lower lid tightening surgery to make his lower lid more symmetric. So there's a lot that goes into trying to rebalance the face and to try to achieve a result that we strive for an A, but we are going for kind of that near normal can be quite a successful outcome as well, just to kind of restore patients and get them doing whatever it was they were doing before in terms of work and socialization. So I'd like to take a couple questions and just take a nod to the multidisciplinary team that we have here. The website that we have here can offer you some additional information if you would like to know more about the treatments. If anyone does have a question, I'm glad to field it. Please do use a microphone if so.
I'm wondering if any of those initial surgeries you talked about, like the brow lift, when you are opening up the eye, does that compromise your eye and the dryness of the eye?
That's right.
And sorry, I'll just add a second one really quick.
Sure.
What is the bite to smile approach that I've heard a little bit about but don't quite understand?
Yeah, the patients who have excessive eye dryness should not undergo any procedure that makes their eye more open. And there are patients who appear to have a very narrow eye opening due to synkinesis, but have such profound eye dryness that they're not a candidate for any eye opening procedure. So that's where I have to work closely with my ophthalmology and oculoplastics colleagues. And actually there were a couple patients shown here where I wanted to do more for their eye, but could not. And so that can be a barrier, but eye health really wins out. If you have to choose between eye health and facial symmetry, that's a really delicate balance, and you have to choose eye health in that instance. And I'm sorry, the second question was the bite to smile? Yes. The bite to smile is essentially a masseteric nerve transfer. Many of the patients that I showed had that procedure done. The masseteric nerve innervates the masseter muscle, which is this very bulky muscle that when you bite your teeth together, you can feel on the side of your cheek. The masseteric nerve has multiple branches, and you can harvest one of those branches through a facelift type approach and connect it to the portion of the facial nerve that's responsible for smile. It is a very effective means of restoring smile in the setting of complete facial paralysis. Does that?
Thanks. Yeah, thank you.
Yeah, the question I have, I'm just curious. Are these procedures covered by insurance, or do?
That's a very common, yes and no, as many things in life, right? And so most of the procedures are. However, there are some procedures and there are some insurers who say no. But the vast majority are. The exceptions can include the hyaluronic acid filler that I discussed. It is a medical device, actually, that's injected into the face. It's classified as a device, and insurers essentially never cover that. But many of the surgical procedures are covered, and botulinum toxin is usually covered with proper documentation and advocacy from a treatment group like ours.
Hi, question on rehabilitation. Other talks I've been to, a lot of the rehabilitation is focused on patients who have had nerve weakness or damage in surgery, but not total paralysis. Does your center do any rehabilitation for patients that have had a nerve graft?
Yeah, in general, for all rehabilitation, when the movement begins, the work intensifies. So in the setting of complete paralysis, there is some work to be done, stretching, massaging, things like that. But the work really ramps up once the movement starts. And in the setting of a nerve graft, there can be a high incidence of synkinesis, and that is where rehabilitation is really effective. It is a bit confusing because there's many roles for rehabilitative treatment that relate to acoustic neuroma, and so this is one subset. So we oftentimes have to coordinate in terms of prioritizing and helping patients choose kind of the when they want to embark on facial neuromuscular retraining. But yes, I hope that helps.
Just a curious question. The patients that you see following treatment, do you see more of them after surgery, or do you see more of them after radiation? And if you have to see one of them, does it make any difference if they've had either treatment?
No, the prior treatment does not make a difference, and it's very difficult for me to assess kind of the frequency of whom I see. Many of the patients have oftentimes had both, because these are the patients with more aggressive and recalcitrant, worse tumors, if you will. So oftentimes they've had both modalities of treatment. It does not appear that the radiation treatment nor surgery that is commonly offered affects the outcomes of facial reanimation surgery. And it's an important consideration for radiation, but specifically for acoustics, it's radiated in a slightly different location. It does not appear to impact the treatment outcomes.
Thank you. So I had a 2.7 centimeter resected by Translab in March of 2017, and they left a piece on the facial nerve. And I did have a CSF leak, which caused left-sided paralysis that recovered within 6 months. The tumor regrew this past year to 2 centimeters on my facial nerve, and I had CyberKnife in June. I had 5 treatments. Before the MRI confirmed the regrowth, I was having more tightness, the synkinesis in my face. Now I'm a nurse, I deal with patients all the time, and so I'm very aware of the synkinesis. Because of the recurrence and because it's now a facial nerve tumor instead of a vestibular nerve tumor, would it be beneficial for me to try to do some rehab at this point? And I'm in Arizona, I'm not here.
Right, it's different. It's difficult to make it that individualized, but in general, when there is abnormal movement, I find rehabilitative treatment to be very valuable. So I usually will just say yes in that setting.
Okay, so I had my surgery with Barrow, so hopefully they have somebody that they can refer that does, because I wasn't offered that after surgery last time. So
I see.
I just didn't know where to go. So I can't come here.
I'd be glad to chat a little bit more after the talk, if that's okay.
Thanks.
All right, of course. Okay, thank you all very much. Appreciate your time.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. please visit us at med.stanford.edu.